Hello and good morning, everybody. My name is Emma Wyatt, and I will be presenting Chapter 10, which covers surfactant medications. For this chapter, we have 6 objectives that we must be able to master. Number 1, define key terms that pertain to surfactant agents. Number 2, list all available exogenous surfactant agents used in respiratory therapy. 3. Describe the mode of action for exogenous surfactant agents. 4. Discuss the route of administration for exogenous surfactant agents. 5. Recognize hazards and complications of exogenous surfactant therapy. And 6. Assess the use of surfactant therapy. Surfactants are indicated for the use of prophylactic and rescue treatments in full-term infants with immature lungs and infants that are born prematurely. Infants born before the 37th week of gestation are considered premature, and there are varying degrees of prematurity. The earlier in gestation that the infant is born, the more complications they can face, especially in regard to breathing. Infants that are born prematurely have underdeveloped lungs and low surfactant production. Surfactant production begins around the 20-week mark of gestation and peaks around 35 weeks. Infants that are born prematurely or with immature lungs will usually develop respiratory distress syndrome or be at risk for developing respiratory distress syndrome. Surfactant is a natural substance produced in our lungs' type 2 pneumocytes. It is considered a detergent or a surface active agent and is a biologically important lipid substance. The reduction of surface tension is one of the most important functions surfactant provides for the lungs. We will explore this function in the next slide to get a more in-depth reason for why it is so biologically necessary. On this slide, we have key terms for the governing principles of surfactant. The first one would be surface tension. This is the attraction of molecules in a liquid-air interface, such as the liquid lining in the lung tissue and the air, pulling the surface molecules inward. Next, we have Laplace's law, physical principle describing and quantifying the relationship between the internal pressure of a drop or a bubble, the amount of surface tension, and the radius of the drop or bubble. On the next slide, I have a diagram that demonstrates Laplace's law. So as you can see here, we have a representation of Laplace's law, which is pressure equals 4 times the surface tension over the radius. But this more so applies to blood vessels. In order for it to apply to the lungs, we have to look at it as pressure equals 2 times the surface tension divided by the radius of the alveoli. On the other side here, we can see a visual representation of surface tension. So we have our gas molecules on the outside, and we have our liquid molecules in here that are being attracted towards each other and creating this concave bubble shape or droplet. Due to the surface tension laws, and obviously that our lungs are wet areas of the body, we can have atelectasis happen if we don't have proper surfactant production to break up this surface tension. This can be thought of like a balloon. The first time blowing up a balloon can be extremely difficult, and this represents what it's like to try and reinflate alveoli without surfactant to break up the tension. If we continually try to reinflate the alveoli that has collapsed due to a lack of surfactant, we can actually cause damage to the lungs from shearing forces. Surfactant's role in reducing surface tension so that we don't have things like atelectasis or shearing forces is primarily found in its chemical composition. Surfactant is composed roughly of lipids, about 90%, and about 10% of proteins. The main lipids found in surfactant are phospholipids and cholesterol, and you can see the phospholipids here in the diagram. The phospholipids are unique in their design as they have a hydrophilic and hydrophobic region, which assists in breaking the surface tension of the water in the air-liquid interface. Surfactant has 4 main proteins that are specific to surfactant. These are known as SPA, SPB&C, and SPD. SPA seems to regulate secretion and exocytosis of surfactant from the type 2 cells and the reuptake of surfactant for recycling and reuse. SPB and C are hydrophobic proteins that improve the adsorption and spreading of phospholipids throughout the air-liquid interface in the alveoli. SPD is up for debate. It is a surfactant-specific protein, and it's relative to SPA, but they don't really know what its function is. So now we are getting into our different types of surfactants. There's 3 main types. There's natural, synthetic, and synthetic natural. There are no current medications for synthetic or synthetic natural. They're being researched though. For the natural, there's Survana, Infisurf, and Curosurf. Survana and Infisurf come from cow lungs, and Curosurf comes from pig lungs. Now we will cover the surfactant agents more in depth. For most of these medications, they will be given via a catheter that is then inserted into an endotracheal tube. Surfactant is indicated as both a rescue and prophylactic treatment. As a rescue treatment for infants with evidence of RDS, this agent should be administered within 8 hours of birth. For premature infants weighing less than 1,250 grams at birth or that has evidence of surfactant deficiency and is at high risk for RDS, this agent should be given prophylactically. As a prophylaxis, it should be given 15 minutes after birth or as soon as possible. The recommended dosing for Surfactant is 100 milligrams per kilogram of weight. Doses can be repeated within at least 6 hours in between. To give a repeat dose, there must be evidence of continuing respiratory distress. Initial dose will be divided into 4 aliquots and given via a catheter. The infant must then be mechanically ventilated for 30 seconds or until stable. During the administration of each aliquot, the infant must be placed into varying positions. Infisurf is indicated for the prevention of RDS in infants born before 29 weeks of gestation. It can also be used as a rescue treatment for premature infants that develop RDS, need intubation, and are less than or equal to 72 hours old. The dosage for Infisurf is 3 milliliters per kilogram of birth weight. As a prophylaxis, it should be administered as soon as possible, preferably no more than 30 minutes after birth. Doses can be repeated for up to 3 total doses. Each dose should be given 12 hours apart, but can be repeated as soon as 6 hours if certain parameters are met. This medication can be given in 2 ways, through a side port or through a catheter. If the side port is used, 2 aliquots should be administered. If administered via a catheter, 4 aliquots should be divided and given. Mechanically ventilate for the recommended times for each delivery method and make sure to position the infants appropriately between aliquots. For the last medication, Curosurf is indicated for the rescue treatment of premature infants with RDS. It can be used off-label. For example, the treatment of infants with severe meconium aspiration. Initial dosing for Curosurf is 2.5 milliliters per kilogram of birth weight, with subsequent dosages of 1.25 milliliters per kilogram of birth weight. Subsequent dosing can be given twice at 12-hour intervals if needed. The maximum dosing is 5 mL per kilogram of birth weight. This includes initial and subsequent doses. Curosurf is divided into 2 aliquots and given via a catheter. The catheter must be removed after the first aliquot, and the infant must be manually ventilated with 100% oxygen for 1 minute before giving the second. Once stable, the infant can be repositioned and given the second aliquot. Now that we are familiar with the medications that we as respiratory therapists use for premature infants and infants that suffer from RDS, we can now get into the hazards and complications that arise from using surfactant agents. Such things as apnea, pulmonary hemorrhage, overventilation, and hypocapnia, high arterial oxygen values, airway occlusion, desaturation, and bradycardia are all possible side effects of using surfactant agents. On this slide, you can see there are some assessments that we as respiratory therapists must make when administering surfactants. Before, there needs to be a need for surfactant agents, which usually will be determined by a doctor. In the short term, we must monitor their pulse and cardiac rhythm, monitor for airway occlusion, which is one of the possible side effects. We should look at their skin color, monitor their physical activity, if they're moving around a lot or if they're very lethargic, and obviously monitor their saturation of O2. In the long term, we need to look for repeat dosing if there's a need for it, and assess their lung mechanics after their initial dose. Some contraindications that we can see with surfactants is the deterioration of pulse, cardiac rhythm, and bad ABG values. Before we wrap up my presentation, I did want to touch on the future of the therapy. As it stands right now, surfactant agents are being looked into as possibly being aerosolized for treatments instead of the use of endotracheal tubes. Endotracheal tubes can cause damage to the lungs. It is also being looked at for meconium aspiration, which we touched on when we talked about Curosurf. I was actually given Curasur for meconium aspiration when I was born. So it is an off-label use and it's not currently approved by the manufacturer, but it is still being researched. It's also being researched as a possible treatment for ARDS in adults, which is adult respiratory distress syndrome. And with that, my presentation is done. Thank you guys for your respect and listening to my presentation. I greatly appreciate it, and if you guys have any questions, please just let me know. Thank you.